our spinal cord stimulator trial section. Dr. Stacy is coming in from Mars, showing us how to do a spinal cord stimulator. Dr. Stacy, can you hear us?
Yes, I can.
Excellent. So this is a really cool part of this lab. If you guys haven't seen this, as you see in your agenda, we're going to have several sections like this where we are in the lab and there's a moderator here kind of fielding any questions, and then we can transmit that to Dr. Stacy. So feel free to ask any questions, but what he's going to do right now is walk through his steps of how he does his needle entry and sends the lead up into the thoracic epidural space. So take it away, Dr. Stacy.
Okay, everybody. Remember I talked about knowing the patient before you started? So I came in and put a lead in to see what it was like before I thought I would show you one. So this is my first lead that I placed. And usually I would not go at L1, L2. I'd usually go a little higher up because there's less mobility higher up. But I wanted to find a nice, big, easy space. And besides, that little IVC filter was a nice little landmark. It was kind of fun to go next to that. So a couple things about what we have here is, I can't really point to the image, can I? But you can see that the needle comes in at a very shallow paramedian angle, that it's really close to the spinous process, and that the lead is, we're finding the epidural space pretty close to midline, and I managed to keep the lead midline all the way up. You can just slide up a little bit, just do an x-ray up here, so we are. And I just threaded up a ways until I got someplace I felt like I could thread forever. This is a 16 contact lead, so go ahead. Which it stays right at the midline. So if I was doing a single lead trial, this would be pretty reasonable for that. One interesting thing, keep that rotation just like that, come down here, is that the patient's a little twisted on the bed, and so what is midline above is not midline down here. So you had to rotate as we went up to correct. The other thing is, as you can tell, the visualization is not really super perfect with this, and that's because of it's a cadaver. So one thing to remember with cadavers, this is a real person. It has family members, and we thank them for their donation to us to allow us to use them for this educational opportunity. Okay, let's come back down to here. So the first thing I do is I try to pick a space that looks reasonable to get in. And you typically want to, from almost everything except for peripheral neuropathy, you want your leads to end up above T12. So anything below T12 is a reasonable place to enter. The lower down you are, the more mobility there is in the lumbar spine, the further you have to traverse. The other thing to remember is that most spinal surgery is down low in the lower lumbar area, so typically you want to be above any prior spinal surgery. So let's take a look here and see what we have. Looking here, if I were to, I'm going to go at the same space, but from the left side now, that would be way too lateral. People talk about all kinds of different landmarks. So I don't really know the full size of this cadaver. They're not very big. But if it's a thick person, starting spot somewhere down here might be appropriate if you want to have a nice shallow angle. If they're really thin, spot, starting someplace, spot, kind of in here might be appropriate. There's a wide ranges of places you can start. So I'm just going to pick right here. And if you look at the spinous process above, I don't know how to point to what's on the screen there. You can see the path of the needle on the right. I want to basically mimic that from the left. So I'm going to, and I use, there's many different needles you can pick. I like the Coude needle. The reason I like the Coude needle is I used it actually with this first patient. The first needle placement, excuse me, I got in nice midline like this. Every time I advanced, it went off to the left. So I turned the bevel back, and now I aimed a little bit to the right, and then it stayed midline. It's really easy to redirect with the Coude, which I think is fantastic. Another advantage of the Coude, if you look at it from this side view, which is like this, is that it makes your angle more shallow. So if you're at an angle like this, by the time it's at the epidural space, the actual insertion angle is more shallow. And occasionally you can need to walk over the lamina, you can walk over the lamina, turn it back, and redirect. So it allows for easy redirection, both to access the epidural space, as well as to, once you're in the epidural space, to redirect the lead. Okay, spot. Come a little bit lateral to that spot. So let's just start here and see what it's like. So usually I place a mark on the patient, but my mark on the patient is this. And I insert, aiming cephalad and medial at the same time, and spot. That's a little bit too lateral, and a little more medial, spot. Spot. So I've touched lamina. If I was in a procedure room with this patient, I would, at this point, put more local anesthetic in to make the rest of the needle insertion more pleasant for the patient. What I do now is just walk off the superior margin of the lamina, which is easy to do on the other side. I'm taking a little bit more work here. Spot, please. I should have picked this side to do first. So I'm having difficulty. I am finding all kinds of crunchiness. Spot. So I'm a little lateral, so I'm going to try to go more midline. Spot.
One of the things I'll interject with is if you guys are doing interlaminar epidural steroid injections, I encourage you to start doing them imagining you're putting in a spinal cord stimulator lead. So you really start to understand those angles and that entry.
Spot. So it's interesting that I had no difficulty with the one I did without you guys watching. And this one is really frustrating me. Spot. And the other thing is, as you can tell, the imaging conditions are not fantastic. Spot. Spot. Any other advice?
Take a deep breath and continue.
Okay, so for the sake of I want to get in and do other things, I'm not going to keep persisting right here. I might persist if I was in the clinic or if one of the fellows that tried, we would do a lot of things to kind of get this in. But that's one of the things about doing this on a live cadaver you've never met before. I mean, a live demonstration on a cadaver you've never met. Let's try it. Let's try the space below. Let's come down a little lower.
Yeah, and this is totally natural. So it's good to see this. You know, he's saying, all right, plan A didn't work out so well. Let's go to plan B. He's going to go to a different level. Totally appropriate. Or maybe you start at a different skin entry point.
Yeah, you can do a lot of different things. I just want to get in.
I think the key thing here, though, is don't get frustrated. Okay? Just it's part of the procedure. Don't start mashing the needle. You still have a patient, you know, that's underneath you.
Spot.
And if by chance you really struggle and you just can't get something in or you can't get a procedure right, abort. It's okay to abort, okay? Not that we're going to do that today, but just in the future. There have been situations with cervical transforaminals where I say, you know, there's intravascular uptake. I'm done. I'm not putting this patient at any further risk.
So I felt it slip over here. I'm going to advance with, I use saline. Okay, that was much easier. Spot. At this point, some people check a lateral view to see where they are. I don't. I just take my lead and see where it goes. So let's scoot up against the bottom of that needle is at the bottom of the screen. I mean, the top of the needle is at the bottom of the screen. No, just go. So I advance until I feel like I'm at the end of the needle. A couple other things. I hold my hands like this so that I'm not like this with my fingies in the x-ray. I want them out of the way of the x-ray, so I hold back here, close to the hub, so I have control as I advance the lead. And we'll just take a picture now, Spot. You see him out with minimal resistance, Spot. And it went way off to the right, which is exactly what happened with the first lead I placed. I'm going to turn the bevel this way, advance a little bit, and Spot. Okay, we'll go pulse or live. As I advance, okay, it's stopped. It's deviating quite a bit right at the beginning. There's not a sense of resistance. It just wants to go that way. So I'm going to turn my bevel more. After pulling the lead back into the needle, I turn the bevel. And the other thing to do is make sure that your angulation of the stylet fits that. So you're aiming left with the stylet and the needle together. Put it in. Okay, spot. Okay, live. Come on, baby. So way closer to midline this time. I'm keeping some tension on it to see if I can get it to go off to that left side. It does not want to go that way. It really wants to drift right. Stop. Okay, this is very real life, like. Entertaining. Any comments, Rambo?
Well, I mean, this is real life, and as you mentioned, as you come lower and lower down in the lumbar spine, there's of course going to be more of the degenerative cascade.
Okay.
So it's not unusual to have these sort of pockets of epidural adhesions or fibrosis that will push your lead off to one direction. If the goal is to really get it more left side, all those steps he's taking are absolutely appropriate. Turning the bevel, putting a little coude tip on the stylet itself so it can help him. He can also push the hub away from him towards the right.
I'll get your assistant to do that as you do that. So sometimes we'll have the assistant or the other person in the room do this.
One of the things you can do is use a straw tunneler with the hook and have the assistant provide that torque. And then lastly, if it's just not cooperating, he can stay in that same interlaminar space, but come back and enter a little bit more to the left side.
Exactly what I'm going to do. So let's come back and look at the needle. I'm so glad I put the first one in with no one watching. It went nice and smoothly.
This is better. This is better that he struggles. It's good.
So last year I had the easiest cadaver on the planet, and this one is not quite that cadaver. So can you move that image to the right on this screen? So I'm going to keep that as a reference so I know where, let me skim that over so I can see it. So I can know where I was. Let's get an X-ray here. So here I am now. I'm going to pull back and try to aim more to the left in that same epidural interlaminar space. That's too much. See what? No, I want that one there for a reference to see where I was before. Spot. So I'm having difficulty advancing over this way. This is probably why I ended up over where I was, because it doesn't want to advance here. Okay, it's going to go now. Spot. I can't quite see it. Okay, that'll be fine. So I feel like I'm over the edge. It's definitely a little bit more lateral than we were before. So I'm going to advance. Okay, there's a nice loss, negative aspiration. This slide up so the needle tip is at the bottom. And even though it's the same interlaminar space, it's going to probably be a totally different world here. You don't really know. Can you correct for that rotational a bit? Come back towards me. But this way. Okay. Good spot. Okay. So I'm going to assume it's going to go right again by aiming a little bit to the left. And we'll see what happens when we get there. One thing with Boston Scientific stylets, everybody has things you like and don't like. I don't like this, but there's not a clear endpoint. There's always some stylet exposed here, so you need to make sure you're in all the way. I've seen plenty of time a fellow is having difficulty steering because it's out like this. There's the end of the green, which you think would be a landmark, but it's not. You go actually past that a little bit to have it out there. So just know that. And again, every stylet is different. The Medtronic has a nice little flat place you hold. They're all a little bit different in how they're built and designed. So you need to know that equipment. But it's like driving a different car. If you know how to drive a car, you can drive it. You can get in a different car and drive it. It's not like you have to learn everything new and different. Okay, spot. Okay, we're going to go live. And this feels much better. Except now it wants to go to the left. So again, I'm not going to advance unless I like where it's going. So there's maybe a reason that we didn't want to get in this space above stop. Okay, live. I'm trying aiming more to the right, see what happens. And it quickly swings back. And it really is going to go, I'll just advance here and show you what's happening. I'm aiming as much as I can to the right, and now it's run into a complete obstruction. It will not go that way. Stop. So I'm going to come back. I'm going to try this again. Okay, live. Okay. So sometimes you have to take what you can get. And take a path that you would not have planned in advance. I want to get a little separation between those. And then bring the tip back. Stop for a second. So right now, if the goal was to stimulate the lower, like this a peripheral neuropathy patient with some back pain, this might be where I might end up trying to stimulate, but it's not usually what you want. You usually want some redundancy and leads side by side. And no one knows exactly what the right space is between the two leads. You don't want them necessarily stacked on top of each other. You don't want a huge space. You want enough space that they can distinguish what they're stimulating. Ideally, get right and left separate. Okay, live. So I'm going to pull back a little bit here and see if I can get...
So one of the advantages of having the other lead in place is that now once he's able to get the second lead in, he can run it along the track of the first lead. So that's where you're seeing that sort of snake-like serpentine motion with the second lead as he stays close to it and then backs off, stays close to it and backs off. This is perfect. And that distance looks great. Just a couple millimeters. We don't want them right on top of each other, as he said, because the stimulation will be impaired, but a little bit of separation is perfect. Like that.
Okay.
Looks great.
So at this point, what I would do is I would pull back the stylets, take an image again. You'll be surprised how much they move sometimes when you do that, and then we trial. So we have two leads in place, and I have them quickly scan through some of the contacts and see where we are. And then if these are actually stimulating only on the right side or the left side, I come back and reposition. So a couple key things about that. One is that was not particularly easy. It wasn't particularly easy to get epidural space, and then it wasn't really easy to advance. Let's check a lateral view, make sure it looks like we think it's going to. Like I said, with traditional stimulation, you will know if they're anterior pretty much every time. You never go through a whole programming session and then discover they're anterior. At least I've never have in my entire life. Have you? Has anybody in the room ever done that? No. It does not happen. If you're doing a non-paresthesia technique, you need to definitely check the lateral view and make sure that you see that your leads are in the posterior epidural space. And you always want to check a lateral view at the end just to confirm and prove that you've done what you said you've done. Often, if their leads are close to each other and the epidural space depends on the shape of the epidural space, the leads basically look exactly at the same plane. They won't be stacked like they are there.
In cadavers, because the CSF pressure obviously is reduced, you will see images like this, but in your live patients, as Brett was saying, they'll be perfectly aligned.
So does anybody have any questions so far with this?
Any questions from the audience? Yes, Mike.
People like putting both needles next to each other,
Mm-hmm.
but down track, thoughts on that?
Yeah, so Dr. Stacy, the question was, and I'm happy to answer this as well, Mike was stating that some people like to put the needles next to each other, ipsilateral.
Yes.
Any comments on that technique?
It's totally a fine technique, and last year I did that. So we brought two in from the right side last year because there was plenty of space to do that. To do that, you have to have one a little bit more lateral. So I don't know how to point to the screen, but you can go really close to each other. It's this. Okay. So show me a. So if these are the two you want to, I can't tell what. Okay, there we go. If you want to go this space, this is your first one. It's obviously really close to the spinous process. You just come in parallel, just a little bit lateral, and find space in there. That's good if there's a nice generous space to get in. So it can be kind of challenging with some spaces where you're not going to get in the right place. The other thing, as we demonstrated down here at the lower level, is where you enter the epidural space sometimes really matters. I was basically in the midline area for the first placement, but only wanted to go one direction. So just a slight variation, a millimeter or two more to the left, changed the whole path of that lead. And so it can work nicely. It's never my first choice thing. It's always my backup plan. If for some reason I can't get in the other side, I go over and try to do ipsilateral. I know how everybody else in the room does this, but I don't plan to do ipsilateral initially. It's a reasonable backup plan if you can't get in from the other side.
So I always do ipsilateral.
You do? Okay.
Always. So all my trials are ipsilateral right, and all my implants are ipsilateral left, just because I want my implant to have the smallest incision possible. I always felt as a fellow, I was trained to come in from both sides. You'd have to make 3 total incisions, right? So I want to do as little incising as possible, so I come in ipsilateral. And I basically, once I get my first needle in, my second needle just basically falls right over it.
Yes.
And then I'm ready to run.
Well, in general, if you're using the same level, the second needle is so much easier because you can see the depth, you can look at your needle, you can see your angle, you can see everything you want to do to make the second needle a little bit better or to follow that track. And there's just a mention about when you get to implant, there's lots of different ways of doing implant. I make my incision before I put the needle placement. Other folks do needle placement, then cut down to anchor. There's lots of different ways of doing these. The important thing is that you get the leads anchored well and securely and don't make extra incision you don't need.
Any other questions? I thought I saw another hand raised. Yes, Mike, another question.
Mechanical loss of resistance?
Mechanical loss of resistance, did you say?
Yeah.
Oh, loss to lead?
Yeah.
Yeah, sure. So Dr. Stacy, the question is, the methods for entering the epidural space, Mike was asking about loss to lead or mechanical loss of resistance. Any thoughts, comments on that?
Everybody's used that. If you've done stimulation, you've had to use that at some point, where you just can't get a resistance, so you've got to do something different. I don't think it's as ideal as loss. I don't find it to be as expeditious as using fluid. Or is definitive. I think fluid's a little bit more definitive feeling than air, even though I learned to do identify the epidural space with air, not fluid. I have certainly used that loss of barrier or advancing with the lead technique. It's definitely not my standard. It might be someone else's standard. Does anybody else have a different comment?
Dr. Beal would like to make a comment.
Yeah, so I haven't used a LOR syringe since they were glass. So I just use I do something radical, like look on the monitor to see where the epidural space is, put the tip there, and then feed the lead in, and it doesn't go advanced anymore. However, you're putting these in the TV needles, or what Dr. Stacy is using here is what's called RX2 coude needle. It has a secondary curve on it. The back part of that needle is very, very blunt. That secondary curve makes it even more blunt. You're putting it at a steep angle. These are designed to get in the epidural space. So just use the anatomy of the needle to your advantage to do that. And remember, if you take especially the RX2 coude, you flip it around so where the sharp end is toward the spinal cord of the quina and the dura, it's quite sharp, especially with the spinal end out. So just remember that, note to self.
Couldn't have said it better myself.
I didn't hear a word of that, so it sounds great, though.
It was amazing.
And I definitely know that people come from different backgrounds and may have learned different techniques of getting there. So I don't know what was being said, but we're all going to talk about what we ended up thinking is a good technique for us, and you will see there's many different techniques that end up being good. So in your fellowship, if you think you've learned the way to do something, no way, no how. So something was said earlier is techniques evolve, technology evolves, procedures evolve. I tell the fellows all the time, I can't think of a procedure I do in 2019 that I learned to do that way when I was in training. Like zero, not a single one. Everything's new and different from what it was back then. And it's good to try lots of different things and figure out what works the best for you. So I don't know what was said, but there's lots of different ways of finding the epidural space.
Any other questions? All right. Dr. Stacy, any closing thoughts? Do you want to go on to implant, or do you want to leave that for me? It's totally up to you.
Do you want to just do it? I'm happy to stop here for now. And then, because I will have time with them, I think, at the stations to do that too. So that way
Okay.